Okay, let's unpack this. We're diving deep today into the latest guidance for managing a critical area in vascular medicine, atherosclerotic disease affecting the carotid and vertebral arteries.
Think of this as your curated briefing, specifically tailored for you, the specialist clinician. We've taken the source material, the full 2023 European Society for Vascular Surgery guidelines, and are extracting the most important updates, the subtle nuances, and those crucial clinical pearls that directly impact your daily practice.
Right, and these aren't just a minor tweak from the previous version, are they? These guidelines represent a really significant revision from 2017.
Oh, absolutely. They integrate a massive 289 new references, pulling in data from recent randomized controlled trials, comprehensive systematic reviews, and, large registry data
And
sets.
what's particularly valuable, I think, is that they don't exist in a vacuum. They offer a really useful perspective by highlighting where they align and also where they differ from other major guidelines out there.
Exactly. Things like the 2021 American Heart Association guidelines on stroke and transient ischemic attack, the European Stroke Organization guidelines, the German-Austrian ones, and the Society for Vascular Surgery guidelines. Understanding those points of agreement and, well, disagreement is key.
So our mission in this deep dive is to walk you through the most critical changes and the entirely new sections that you absolutely need to be aware of.
This covers everything from updated targets for best medical therapy to the subtle nuances in how and when we intervene, the specific techniques we use.
And even shedding light on the big unanswered questions that are actively shaping the future research agenda in this field. It's quite comprehensive.
It really is. We're going to cover a lot of ground. We'll get into the updates on managing both asymptomatic and symptomatic carotid disease, look at the latest on antiplatelet and antithrombotic strategies.
Discuss important perioperative considerations, delve into the techniques for both carotid and vertebral artery interventions.
And even touch upon how we manage patients who also have concurrent cardiac issues, or, say, supraaortic arch disease.
Okay, here's where it gets really interesting. These guidelines aren't just tweaking existing sections. They feature 5 entirely new sections addressing specific, often complex clinical scenarios.
That's right. These cover the management of free-floating thrombus in the carotid artery, navigating tricky things like carotid webs.
Managing those symptomatic patients who have both an ipsilateral 50 to 99% carotid stenosis and atrial fibrillation, that's a tough one.
Definitely. Plus, detailed guidance on planning interventions in patients who are already on anticoagulation, and really crucial timing considerations for interventions in patients who have had an acute ischemic stroke and undergone thrombolysis.
So we'll explore these new areas and many other revised sections throughout our deep dive.
So at the end of all this, what does this comprehensive new guidance actually mean for how you approach and manage patients with carotid and vertebral artery disease in your clinic or operating room? Let's dive in and find out.
Okay, let's start by setting the stage with some fundamental definitions and clarify how we measure things in this space because, well, even the language has evolved a bit.
The guidelines note a shift in terminology away from the older term cerebrovascular accident. Now, we're generally using transient ischemic attack or TIA or simply stroke.
And it's really important to have a clear understanding of primary versus secondary prevention in this context, isn't it? The goals are quite different.
Absolutely crucial. Primary prevention is focused on reducing the clinical impact of asymptomatic carotid or vertebral artery stenosis, those blockages that haven't caused symptoms yet, basically, trying to prevent a patient's first TIA or stroke.
Right.
Secondary prevention, on the other hand, is all about preventing recurrent events in patients who have already experienced a TIA or ischemic stroke that's, believed to be caused by carotid or vertebral artery stenosis.
Okay. Now, thinking about the underlying causes of stroke, the guidelines give us that basic breakdown.
Yes, they remind us that about 15 to 20% of strokes are hemorrhagic bleeding, either within the brain tissue itself, intracranial hemorrhage, or in the space around it, subarachnoid hemorrhage.
And importantly, they point out that about 20% of all ischemic strokes, the ones caused by blockages, originate in the vertebrobasilar system.
Correct, affecting the back of the brain, controlling balance, coordination, vital functions.
And to categorize these ischemic strokes, we often use classification systems, right? Like the TOAST system.
Yes, the trial of ORG 10172 in acute stroke treatment, or TOAST classification, it's widely used. It divides ischemic strokes into 5 main buckets: large artery atherosclerosis, which is our focus here.
Mm-hmm.
Cardioembolic strokes originating from the heart, small vessel occlusion, other less common defined causes like arteritis or dissection, and then cases where the cause remains undetermined.
And the guidelines cite a study showing large artery atherosclerosis accounts for
About 16.6% of ischemic strokes in that particular study of over 2,000 patients.
And drilling down into that group, how often is a significant carotid stenosis the culprit?
Well, in that same study, an ipsilateral 50 to 99% carotid stenosis blockage on the same side as symptoms was found in about 8% of those large artery atherosclerosis stroke patients.
Okay.
Complete occlusion or significant intracranial blockages were less common, around 3.5% each. Another study they mentioned looks specifically at patients with carotid territory symptoms
Yes.
and found 12.5% had a significant 50 to 99% ipsilateral stenosis, plus another 5% or so had a complete occlusion. So it gives you a feel for the contribution.
What's also interesting, and the guidelines highlight this, is that the proportion of strokes caused by large artery atherosclerosis seems to be declining over time.
Yes, that's a really encouraging trend. It's thought to be linked to and potentially driven by significant improvements in best medical therapy.
Like better cholesterol control, blood pressure management.
Exactly. Stricter control of lipids, lower average blood pressures, higher HDL, and much wider use of antiplatelets, antihypertensives, and crucially, statins.
And there's data showing fewer significant stenosis being found.
Yeah, data cited from 2002 to 2014 showed a 30% decline in 60 to 99% stenoses and a 36% decline in 80 to 99% stenoses among patients referred to TIA or stroke services.
Wow. That strongly suggests better medical management is really making a difference.
It really does seem to be positively impacting the natural history of the disease.
Okay, let's pause for a quick micro recap here.
Mm.
We've clarified the shift in terminology to TIA and stroke,
Mm-hmm.
distinguished between primary and secondary prevention goals,
Mm-hmm.
discussed the breakdown of stroke etiology using TOAST, the specific contribution of large artery atherosclerosis and carotid stenosis,
Right.
and highlighted that really encouraging trend of declining large artery atherosclerosis strokes, likely thanks to advances in best medical therapy.
Absolutely. And one absolutely crucial detail for anyone working in this field, especially you as specialist clinicians interpreting imaging reports, is understanding how carotid artery stenosis severity is actually measured.
Ah, yes, the historical measurement methods.
Exactly. The major trials that define how we manage carotid disease use two different methods. The European Carotid Surgery Trial, or ECST method,
Right.
and the North American Symptomatic Carotid Endarterectomy Trial, or NASET method.
And the key difference lies in the denominator, doesn't it? What they're comparing the narrowing to.
Precisely. With the European Carotid Surgery Trial method, the denominator is the estimated diameter of the normal vessel at the level of the stenosis, typically measured in the carotid bulb that naturally widened part.
Okay.
With the North American Symptomatic Carotid Endarterectomy Trial method, the denominator is the diameter of the disease-free internal carotid artery above the stenosis, where the vessel walls are parallel.
So different reference points mean different percentages for the same narrowing.
Exactly. It can cause real confusion if you don't know which method is being reported. For example, a 50% stenosis measured by NASET is roughly equivalent to a 75% stenosis by ECST,
Okay.
and a 7% NASET equates to about an 85% ECST. The guidelines primarily adopt the NASET method now, unless they state otherwise.
But there's a really important clinical caveat here, which they emphasize. The NASET method doesn't work so well for certain types of plaque.
That's the critical point. It struggles when there's a large volume of plaque sitting within a significantly dilated carotid bulb.
Right. So if the bulb is wide and filled with plaque, but the channel through it is still maybe almost as wide as the normal artery above.
Exactly. NASET might report that as less than 50% stenosis because its reference point is that narrower artery above.
Mm-hmm.
But if you use the ECST method, estimating the original size of that dilated bulb before the plaque, the stenosis could easily be measured as greater than 70% due to the sheer bulk of the plaque.
I see.
So the guidelines make a critical point. Symptomatic patients who have these large volume plaques in a dilated bulb, consistent with an ECST measurement greater than 70%, should still be considered for revascularization, even if the NASET number is below 50%.
That's a fantastic clinical pearl. It's about morphology and location, not just the raw percentage, especially in those bulbs. Requires real clinical judgment.
Precisely. You have to look beyond the number. The guidelines also touch upon the increasing role of functional imaging, things like CT perfusion or MRI.
Right. What do they have?
Well, in asymptomatic patients, finding a silent infarction, a small stroke that didn't cause obvious symptoms on these scans, means a higher risk of future stroke.
Okay.
And in symptomatic patients, if the acute infarction seen on preoperative imaging is larger, that predicts higher risks, like stroke or bleeding after revascularization.
Okay, that lays the groundwork nicely. Let's move beyond the basic definitions and measurement and dive deep into managing asymptomatic carotid disease, or ACS. How is this defined?
Asymptomatic carotid artery stenosis, ACS, is defined as finding a stenosis in patients who have no clinical history of ischemic stroke, TIA, or any other neurological symptoms you could clearly attribute to the carotid arteries.
Okay. And that aligns with the criteria from the big trials like ACS and ACST1.
Yes, ACS used that definition. ACST1 required no referable symptoms within the preceding 6 months for inclusion.
Now, a major emphasis in these new guidelines, reflecting how things have evolved, is the significantly expanded section on optimal medical therapy, or best medical therapy, BMT.
Absolutely. It's much more detailed now, and it applies to both asymptomatic and symptomatic patients.
So what are the key updates and recommendations regarding BMT, specifically for asymptomatic carotid disease?
It starts by really hammering home the importance of lifestyle factors. They cite meta-analysis data showing smoking significantly increases the prevalence of severe ACS, accelerates plaque progression, and substantially bumps up stroke risk.
And exercise.
Big benefit there. Moderate to high levels were linked to a 25% relative risk reduction in stroke. They reference the American Heart Association's recommendation: at least 150 minutes a week of moderate intensity or 75 minutes vigorous.
Right. And obesity.
Also linked to major increases in stroke risk. Plus, they mentioned behavioral counseling helping patients with diet and activity can reduce overall cardiovascular events by improving blood pressure, LDL, glucose, and obesity.
Makes sense. What about lipid-lowering therapy? Any updates beyond just take a statin?
Yes, recommendation 13, which is marked as changed, makes a strong class 1, level B recommendation for lipid lowering with statins, potentially adding isotemy for long-term prevention of stroke, MI, and other cardiovascular events in all patients with ACS.
Okay, that's a strong baseline. What if patients can't tolerate statins?
That's where recommendation 14, which is new, comes in. It suggests considering PCSK9 inhibitors for patients with dyslipidemia who are intolerant of statins, even with isotretinoin. This is class 2A, level C, indicating it's a reasonable option in that specific scenario based on expert consensus or limited studies.
Got it. And diabetes management. Still crucial.
Absolutely. Recommendation 16, unchanged, recommends optimal glycemic control for diabetic patients with ACS. It's class 1, level B.
Even though tight sugar control alone hasn't always directly shown reduced stroke risk in all meta-analyses?
Right, but specific drugs used in diabetes, like atorvastatin in the CARDS trial or pioglitazone in perioperative, have shown stroke reduction benefits. So optimal glycemic control remains a key part of the overall risk factor management package.
Okay, let's synthesize that BMT advice for asymptomatic disease. It's aggressive lifestyle changes, intensive lipid lowering aiming for low targets, possibly using PCSK9 inhibitors if needed, and strict glycemic control for diabetics. What are the specific targets they recommend for blood pressure and lipids? These seem quite detailed now.
They are very specific. For blood pressure in non-diabetics under 65, the target is less than or equal to 130/80.
Okay.
For non-diabetics 65 and older, it's systolic 130/139 and diastolic less than 80.
Right, and for diabetics.
Under 65, systolic 120/129, diastolic 70/79. 65 and over, systolic 120/139, diastolic 70/79. So slightly tighter targets for younger diabetics.
Those are quite granular.
Yeah.
And the cholesterol targets, also pretty ambitious.
Definitely. Total cholesterol less than 3.5 millimoles per liter, which is under 135 milligrams per deciliter.
Okay.
And LDL, the bad cholesterol, less than 1.8 millimoles per liter or under 70 milligrams per deciliter.
Wow, under 70 for LDL.
And for patients considered even higher risk, they suggest aiming even lower, less than 1.4 millimoles per liter for LDL.
Those are certainly tough targets to hit and maintain. Which brings us to adherence. Do the guidelines mention barriers?
Yes, they list several factors. cognitive impairment, lack of insight or belief in the treatment benefits, mental health issues, poor follow-up, medication cost, and just the complexity of the regimen.
And adherence really matters for outcomes.
Hugely. They cite a simulation model showing significantly higher long-term survival in patients who stayed compliant with their BMT compared to those who didn't.
Makes sense. Okay, moving beyond medical therapy, what about screening for asymptomatic carotid disease in the general population? What's the guideline perspective?
They evaluate screening using standard public health criteria. Is it important, preventable? Is there a good test? Accepted treatment? Is it cost-effective?
And preventing stroke from carotid stenosis is definitely considered important.
Absolutely. Section 2.2 highlights the massive burden and costs of stroke globally.
So given that, is widespread screening recommended? What's the prevalence like?
Well, in the general population, the prevalence of greater than 50% ACS is about 2%, and greater than 70% is only about 0.5%. It does increase significantly with age, though.
Right. Table 6 shows that clearly. Like 6% over 50% stenosis in men aged 70 to 79.
Exactly. And they also mentioned that overall global prevalence of greater than 50% ACS seems to have increased since 2000 in 30 to 79-year-olds.
But despite that, mass screening isn't the answer.
Correct. The guidelines conclude that unselected screening of the general population under 80 yields a detection rate for greater than 70% stenosis of less than 2%. That low yield is considered neither cost-effective nor clinically effective.
So instead of mass screening, the focus shifts to identifying higher risk groups who might benefit more from targeted screening.
Precisely. They discuss models like the one by Portheus and colleagues. Predictors for higher risk included things you'd expect: age, male sex, smoking, diabetes, prior stroke DA, coronary artery disease, peripheral artery disease, high blood pressure, raised lipids.
And if you screened just the highest risk individuals using that model, what was the yield then?
Focusing on the highest risk decile, you detect one patient with greater than 50% stenosis for every 13 screened, and one with greater than 70% for every 58 screened.
Still a fair number of scans, but much better than unselected screening.
Right. It could potentially identify around half of all people with significant stenosis by screening just that top 10% risk group, making it a much more efficient approach.
Okay, that's a really clear picture. Screening, maybe not for everyone, but potentially for carefully selected higher risk groups. Let's take another micro recap here to consolidate our understanding of asymptomatic disease so far.
Sounds good.
We've defined asymptomatic carotid stenosis, explored the extensive updates and specific targets for best medical therapy, including lifestyle, lipids, diabetes, and blood pressure. And reviewed the evidence and recommendations regarding screening, noting unselected screening isn't recommended due to low yield, but targeting high-risk groups appears more promising.
Absolutely. Now, within this discussion of asymptomatic carotid stenosis, there's a significant ongoing controversy that the guidelines address head-on.
Which is?
It's the question of whether the data from those older foundational trials like ACAS and the ACSD1, the ones that showed a benefit for surgery in reducing stroke in asymptomatic patients, are still fully relevant today.
Because medical therapy is so much better now.
Exactly. With widespread statin use, better blood pressure control, more smoking cessation, the thinking is maybe the natural risk of stroke from ACS on modern BMT alone is much lower than it was back then.
Which would mean the potential benefit from surgery or stenting might be smaller, shifting that risk-benefit calculation.
That's precisely the core of the debate. And the guidelines cite evidence supporting this shift. A large meta-analysis looked at stroke rates in asymptomatic patients on medical therapy alone over time.
What did it find?
It found rates of ipsilateral stroke on the same side as the stenosis were 2.3 per 100 person years in studies recruiting before the year 2000,
Cool.
versus a much lower rate of 1.0 per 100 person years for studies recruiting between 2000 and 2010. That's a significant decline, attributed to improvements in BMT and smoking cessation.
And did they link that specifically to statin use?
Yes, well, the guideline text mentions an inverse relationship, although the specific numbers cited 1.2% stroke rate where 25% use statins versus 2.3% where 25% use statins seem counterintuitive as written in the source.
It does sound backward if statins are protective.
It does. It might be a typo in the guideline text or refer to specific subgroups, perhaps. However, the overall message from that section and other cited reviews is very clear. Higher statin use generally correlates with lower stroke rates, And annual stroke rates have consistently declined across all ACS severity grades over time.
Right. So the big picture is the risk for asymptomatic patients just on medical therapy is likely lower now than when the big trials were done,
Correct.
which means the decision to intervene more complex. If the baseline medical risk is lower, who should we still be considering for surgery or stenting? How do the guidelines help us identify those asymptomatic patients who are truly at high risk of stroke on medical therapy despite getting optimal treatment?
This is a really important area, and the guidelines dedicate significant attention to it. Different international guidelines have slightly different takes.
Like the SVS.
The Society for Vascular Surgery guidelines recommend carotid endarterectomy in asymptomatic patients with 70 to 99% stenosis if they are low surgical risk.
And the AHA.
The American Heart Association is more cautious, advising intervention only for highly selected patients, but without clearly defining highly selected.
Okay. What about European guidelines?
The European Society of Cardiology considers any asymptomatic carotid stenosis, even without other clinical vascular disease, to place a patient in the same very high-risk category as someone with known CAD or PAD, mainly for risk factor targets. The European Stroke Organization recommends CEA for 60% or greater ACS if the patient is deemed at increased risk of stroke despite VMT.
And how do they define that increased risk?
Crucially, they explicitly cite the specific higher risk criteria that were published in the 2017 European Society for Vascular Surgery guidelines.
So the previous ESVS guidelines really pioneered identifying these specific features, and the new ones build on that. What are those specific criteria for identifying this higher risk cohort?
Yes. Table 8 in the current guideline summarizes them, and these are based on solid evidence meta-analyses, multi-center studies, RCT subgroup analyses, not just single-center stuff.
Okay, what are they?
First, finding a silent infarction on a brain CT or MRI scan. Second, significant stenosis progression, 20% or more increase over time. Third, specific ultrasound plaque features. A large plaque area or a large juxtaluminal black area suggesting an unstable lipid core.
Right, looking at the plaque itself.
Exactly. Fourth, overall plaque echolucency on ultrasound, again, looking dark suggests instability. Fifth, intraplaque hemorrhage, bleeding within the plaque, usually seen on MRI.
Okay.
Sixth, impaired cerebral vascular reserve, meaning the brain's struggling to compensate for the reduced flow. And seventh, detecting spontaneous microembolic signals on transcranial Doppler monitoring.
Can you quickly explain cerebral vascular reserve and microembolic signals again?
Sure. Impaired cerebral vascular reserve means the brain's ability to increase blood flow when needed is reduced because of the stenosis. It's working near capacity already. Microembolic signals on TCD are like tiny blips, thought to be small particles breaking off the plaque and heading towards the brain, a sign of an active, unstable plaque.
So finding one or more of these features, silent infarct, unstable plaque signs, poor flow reserve, or emboli flags, an asymptomatic patient is higher risk, even on good medical therapy.
That's the concept, yes. These features help differentiate higher risk from lower risk stenosis, guiding the intervention decision beyond just the percentage narrowing.
And the guidelines specifically decided not to include just having a very tight, say 80 to 99% stenosis alone as a high-risk criterion.
Correct. There was a debate and a majority vote against that, 11-3. It reflects the thinking that plaque biology and brain hemodynamics might be more important risk drivers than the exact percentage once you're in the severe range.
That's a significant shift in thinking. What about ongoing surveillance for asymptomatic patients, say someone with 50 or 60% stenosis without these high-risk features?
Recommendation 48, which is new, addresses this. It suggests that for patients with 50 to 60% ACS who would consider future intervention if indicated, it's reasonable to offer annual duplex ultrasound surveillance, Class 2B, Level C.
And the goal of that surveillance, is it just watching the number go up?
Not just that, it's partly for ongoing risk factor monitoring and reinforcing BMT adherence. But clinically, it's crucial for monitoring the stenosis itself, looking for progression to, say, 60 to 99%, or for the development of those higher risk features we just discussed, like increasing plaque lucency, or maybe detecting microemboli if TCD is used.
So watching for qualitative changes, too.
Exactly. If those features appear, the patient might then be reclassified as higher risk. The German-Austrian guidelines say something similar.
How long should surveillance continue?
No consensus on that. It requires shared decision-making, considering the patient's wishes and health and local policy. Importantly, surveillance is not indicated if the patient wouldn't consent to intervention anyway, but they should still be told to seek urgent help if symptoms occur.
Okay, we've covered a lot on asymptomatic disease, the BMT targets, screening rationale, the modern context controversy, high-risk criteria beyond percentage, and surveillance. Let's take another quick micro recap.
Okay. Asymptomatic carotid disease, defined by stenosis without symptoms. Management starts with rigorous BMT with specific aggressive targets. Unselected screening isn't recommended, but targeting high-risk groups might work. Intervention's role is debated in the modern BMT era, but guidelines identify specific clinical imaging features defining higher-risk patients beyond just stenosis percentage. Annual DUS surveillance is reasonable for selected patients, 50–60% stenosis would consider future intervention, to monitor for progression or high-risk features.
Excellent. Now let's briefly touch on the randomized trials comparing carotid endarterectomy, CEA, and carotid artery stenting, CAS, specifically in asymptomatic patients. What's the latest evidence?
A meta-analysis pooled 6 RCTs, over 7,000 asymptomatic patients, comparing CEA versus CAS, specifically excluding just angioplasty without a stent.
And the main findings on short-term outcomes, say, at 30 days.
At 30 days, CAS, mostly transfemoral CAS in these trials, had higher rates of any stroke and higher rates of death combined with any stroke compared to CEA. The odds ratio strongly favored CEA for lower early stroke risk.
So, CEA safer short-term for stroke in asymptomatic patients in these trials. Any endpoints favoring stenting?
Yes, CAS had a lower rate of myocardial infarction or heart attack at 30 days compared to CEA. Statistically significant benefit for stenting regarding acute heart risk.
Okay.
No major differences in other endpoints like disabling stroke or death-disabling stroke.
That really highlights the different risk profile surgery. Lower stroke risk, but maybe higher heart risk.
Yeah.
Stenting the opposite.
Exactly, which presents a clinical choice, especially in patients with significant heart disease. This also ties into the debate about the safety threshold for intervention.
Right, the historical 3% 30-day stroke death threshold. Did the committee consider lowering it, given potential BMT improvements?
They discussed it, but decided not to reduce the 3% threshold for asymptomatic intervention at this time.
Why?
Several reasons. Differing views on whether BMT has truly lowered the baseline stroke risk enough. Also, meta-analyses of the big CEA versus CIS trials reported 30-day death stroke rates of around 2.2% for CEA versus 3.1% for CAS.
So not consistently way below 3% and still a difference between procedures.
Right. Keeping the 3% threshold aims to avoid potential delays if centers felt they needed to hit even lower rates, recognizing that delays increase the risk of waiting events, especially in symptomatic patients, which we'll get to.
That makes sense. And you mentioned the CREST-2 trial earlier.
Yes, CREST-2 is ongoing. It's randomizing asymptomatic patients to CEA, CAS, or BMT alone. It should hopefully help answer some of these lingering questions about the best approach for asymptomatic disease today.
One other topic in the asymptomatic section. The potential link between ACS and cognitive impairment or dementia. What's the evidence?
Well, vascular causes contribute a lot to dementia, and there's been speculation that ACS might play a role, maybe through silent strokes or reduced blood flow. Systematic reviews found associations between ACS and cognitive impairment in observational studies.
But association isn't causation, right?
Exactly. That's the critical point the guidelines make. The reviews couldn't unequivocally prove ACS causes cognitive dysfunction. The mechanisms white matter changes, lacunar infarcts, microemboli are still being investigated. Surprisingly few studies directly linked ACS, visible silent infarcts, and objective cognitive measures.
What about the reduced blood flow idea, impaired cerebral vascular reserve? Could that be a link?
That's one hypothesis. One study looked at ACS patients with 80–99% stenosis and impaired CVR.
What did it find?
It found that those with impaired CVR who underwent CAS showed cognitive improvements afterwards. Control patients with impaired CVR who didn't get stenting showed no change, and patients with normal CVR who got stenting also showed no change.
Intriguing. Suggests that in that specific subgroup with impaired flow, intervention might help cognition.
Potentially, yes. But what about the bigger picture? Did the large asymptomatic trials look at long-term dementia?
What question?
A post hoc analysis of the ACST1 trial data, looking out 10 and even 20 years using electronic health records, specifically checked for recorded dementia rates.
Yeah.
They found no statistically significant difference in recorded dementia rates between patients randomized to CEA and those managed with BMT alone.
So despite the observational association and that intriguing CVR subgroup finding, the long-term ACST1 data didn't show surgery prevented dementia overall.
Precisely. The guidelines conclude that while ACS patients with impaired CVR might be more likely to decline cognitively, there's currently no compelling evidence from the major trials that CEA or CAS improves or prevents cognitive impairment or dementia overall in asymptomatic patients.
Okay, that provides a really comprehensive overview of asymptomatic carotid disease management. We've covered BMT, screening, the modern context, identifying high-risk patients, surveillance, CEA versus CAS trial data, and the cognitive link.
Yes, that covers the major points in Section 3.
Let's transition now to symptomatic carotid disease, SCS. Patients who've already had a TIA or stroke attributed to their carotid. Here, intervention is more established, right?
Yes, symptomatic carotid disease is defined as stenosis in patients who've recently presented with a TIA or ischemic stroke referable to the carotid arteries.
And what are the timing of interventions in these patients? This seems absolutely critical.
It is. The guidelines strongly reinforce the need to treat symptomatic patients as soon as possible after a TIA or minor stroke. Section 4.5 really emphasizes this urgency.
Is there a strong recommendation on the time frame?
Yes. Recommendation 58, marked as changed, is very clear. It recommends carotid revascularization, either CEA or CAS, for patients with 50 to 99% ipsilateral stenosis as soon as possible after a mild or moderate stroke or TIA. Ideally within 7 days, and certainly within 14 days.
Class 1, level A evidence for that. That's strong.
Very strong, based on multiple large, high-quality RCTs or meta-analyses.
Why the urgency? Where does that level A evidence come from?
It comes from the known high risk of recurrent stroke very soon after a TIA or minor stroke caused by carotid stenosis. Reanalyses of NASET, ECST, and newer studies like SVACS consistently show the risk of a disabling or fatal stroke peaks in the immediate days and weeks after the first event.
Okay.
Acting quickly within that early window significantly cuts down that high recurrence risk compared to delaying intervention. Some analyses suggest intervening within 14 days, even with a theoretical 10% procedural risk, prevents more strokes long-term than waiting 4 weeks and having a 0% risk then.
Wow. That really underscores that the risk of waiting might outweigh the procedural risk, even if intervention isn't zero risk. But are there increased risks with operating very early, like within the first day or two?
Yes, there's some evidence suggesting a trade-off there. While delaying beyond 14 days is clearly bad, registry data and meta-analyses suggest operating extremely early within 48 hours might carry slightly higher procedural risks for CEA.
Higher stroke and death rates.
Yes, one meta-analysis found higher 30-day stroke death with CA within 2 days versus days 3 to 14. Comparing within 7 days versus 8 to 14 days showed a non-significant trend towards higher risk in the earlier group for CEA.
And what about CAS in that very early period? Similar concerns.
Registry data on CA's timing is a bit inconsistent, but some studies suggest higher early risk too. A specific meta-analysis showed a statistically significant higher risk of 30-day stroke, odds ratio 1.8, if CAS was done within 7 days versus 8-14 days, though no difference in mortality.
So it seems both procedures might be slightly riskier if done extremely early, day 1 or 2, but the benefit of intervening within 2 weeks is clear for preventing recurrence.
Precisely. And the guidelines present data directly comparing CEA versus CAS based on timing from the Carotid Stenting Trialists Collaboration meta-analysis.
What did that show?
Striking differences. For interventions within 7 days of symptoms, CEA had a 1.3% 30-day death stroke rate, significantly safer than CAS, which had 8.3%.
8.3% risk with stenting within 7 days versus 1.3% with surgery. That's a huge difference early on.
It is, and even in the 8 to 14-day window, transfemoral CAS still had significantly higher death stroke at 8.1% compared to 3.4% for CEA.
Given these higher risks, particularly with stenting early on, Why did the guideline committee decide to keep the historical 30-day risk threshold at 6% or less for stroke death after either CEA or CAS in recently symptomatic patients? Why not lower it?
The main reason was to avoid causing unnecessary delays. They recognized that setting a stricter threshold, say below 2 or 3%, might make some centers delay procedures in higher-risk patients to meet the target.
Right.
But delaying directly exposes the patient to that high inherent risk of early recurrent stroke while they wait. Keeping the 6% threshold encourages prompt intervention within 14 days, prioritizing preventing recurrent strokes over achieving ultra-low individual procedural rates while still expecting centers to aim for the lowest rates possible. It's a pragmatic balance.
That clarifies the dilemma balancing immediate procedural risk against the very high risk of waiting too long.
Exactly.
What about intervening in patients who are neurologically unstable, say after a large stroke, or if they're significantly impaired?
Recommendation 61, unchanged, addresses this. It recommends not performing CEA or CAS in patients with a disabling stroke, typically modified Rankin scale score of 3 or higher, or if the infarct area is large, say more than a third of the MCA territory, or if they have altered consciousness. Delay revascularization until neurological improvement occurs. Class 1, level C.
And the reasoning: higher risk of complications.
Yes, significantly higher risk. Primarily hemorrhagic transformation of the infarct bleeding into the stroke area or a new intracranial hemorrhage. One study showed large infarct size predicted post-op non-ischemic complications like hyperperfusion syndrome and ICH.
Okay, makes sense. Avoid adding procedural risk onto an unstable or severely injured brain until things settle down.
Right. Patient safety first in that situation.
Let's move to one of the new sections, timing interventions after intravenous thrombolytic therapy. What are the concerns here?
The primary concern is bleeding risk. Doing CEA or CAS too soon after giving a clot buster like TPA increases the risk of hemorrhagic transformation in the brain and also neck hematoma after CEA.
Okay, but some patients getting thrombolysis will have an underlying carotid stenosis needing treatment.
Yes, maybe 10 to 20% might have a 50 to 99% stenosis that could be the culprit and might benefit from revascularization eventually.
So how do you decide who gets early intervention after thrombolysis and when?
The guidelines outline general criteria for selecting patients for early CEA post-TT, trying to balance stroke prevention and bleeding risk. These include rapid neurological recovery, MRS 02, relatively small infarct, 13 MCA territory, maybe confirmed vessel recanalization, the relevant stenosis, 50-99%, and crucially, no significant brain hemorrhage or edema on imaging.
And contraindications for early intervention post-TT.
Severe persistent deficit, MRS3, anticipated high surgical risk anyway, any parenchymal hemorrhage on CT or prior radical neck dissection or radiotherapy.
So if a patient meets the criteria and has no contraindications, when should the intervention happen after thrombolysis? What does the evidence show?
A systematic review compared outcomes in patients who got TT before CICAs versus those who didn't. It found TT was associated with higher rates of ICH and neck hematoma after CEA and higher stroke death and ICH after CAS.
So definitely increased bleeding risks. What's the specific timing recommendation then?
Recommendation 62, which is changed, suggests considering a delay of at least 6 days after thrombolysis completion before performing CEA for symptomatic patients with 50 to 99% stenosis, Class 2A, Level B.
Why specifically 6 days?
It's based on a meta-regression analysis looking at how complication risk changes over time post-TT. 6 days was the minimum delay estimated to bring the 30-day death stroke rate after CEA back down within that 6% acceptable threshold.
Is there an unanswered question related to this timing?
Yes, the guidelines explicitly highlight one. Should symptomatic patients who get thrombolysis but have no acute infarction visible on their post-treatment CT MRI, maybe because symptoms were brief or the brain was resilient, still have to wait the full 6 days? That needs more research.
Okay, that's a lot of crucial detail on timing interventions, especially after symptoms and thrombolysis. Let's pause for another micro recap.
Okay. For symptomatic carotid disease, strong recommendation for revascularization, ideally within 7, certainly within 14 days of mild moderate stroke I, Class 1, Level A, to minimize recurrent stroke risk. CEA generally appears safer than TFCAS within this early window for stroke risk. The guidelines maintain a 6% 30-day risk threshold to avoid delays. Intervention is contraindicated in unstable patients with large infarct deficits. New guidance suggests a minimum 6-day delay for CEA after thrombolysis, Class 2A, Level B, to mitigate bleeding risks, noting an open question for patients without evident infarct post-TEA.
Moving on, the guidelines introduce a new section on managing symptomatic patients who also have atrial fibrillation. Recommendation 63, new. What does it say?
This tackles the common challenge. Patient presents with stroke IA, has a 50 to 99% ipsilateral carotid stenosis, and has AF. The guidelines recommend a comprehensive neurovascular workup and multidisciplinary team review. Class 1, Level C.
And the goal of that MDT review?
To figure out if the symptoms were most likely from the carotid stenosis or cardioembolic from the AF. Based on that, decide. Urgent carotid revascularization or anticoagulation alone first. It's complex distinguishing the source.
And if anticoagulation is started for suspected AF source, but the patient has recurrent symptoms in that carotid territory?
Recommendation 64, also new, covers that. If a patient has recurrent events ipsilateral to a 50 to 99% stenosis while on therapeutic anticoagulation, then CEA or CAS is recommended. Class 1, Level C. Basically, the carotid lesion is still causing trouble despite anticoagulation.
Got it. Another new section, 4.2.6, covers planning interventions in patients already on anticoagulation. Key considerations.
Emphasis on MDT discussion, especially if thrombotic or bleeding risks are high, ideally involving coagulation specialists. Document the agreed perioperative strategy clearly and crucial. Careful post-op blood pressure control is vital to reduce neck hematoma and ICH risk.
Is there a specific recommendation about continuing antiplatelet therapy in these anticoagulated patients?
Yes. Recommendation 56, new, suggests continuing single antiplatelet therapy, usually aspirin, for patients undergoing CAAs who are on vitamin K antagonists, VKAs, like warfarin, or direct oral anticoagulants, DOACs, alongside careful perioperative management of their anticoagulation. Class 1, Level C.
And how is that careful management of anticoagulation typically approached? Stop the anticoagulant beforehand?
Yes, usually stop the VKA or DOAC preoperatively for a defined period based on the drug and kidney function. During this time off, continue or start single antiplatelet therapy.
Okay.
For CAS specifically, some prefer stopping the anticoagulant and using combination antiplatelet therapy, aspirin plus clopidogrel, periprocedurally for stronger antiembolic protection. If doing that, start the combo therapy the day after stopping the VKA.
But deciding when to stop the combo therapy and restart anticoagulation post-procedure needs careful MDT input.
Absolutely critical. It requires balancing bleeding risk against clotting risk off anticoagulation or on the stent. Needs individualized planning.
That leads nicely to another area with new sections, combination antiplatelet therapy, or dual antiplatelet therapy, DAPT, in recently symptomatic patients and around intervention. What's the evidence for using two agents together?
Section 4.2.2.2 discusses DAPT in recently symptomatic patients before intervention, and other sections cover perioperative use. The rationale comes from evidence that many T-asthma strokes involve unstable embolizing plaque.
Right.
A meta-analysis of RCTs in high-risk T-asthma stroke showed early DAP, usually aspirin plus clopidogrel, significantly reduced subsequent stroke, disability, and improved quality of life at 90 days compared to aspirin alone.
That sounds like a strong argument for using DAPT early after a high-risk TIA or minor stroke, regardless of intervention plans.
It is, and the guidelines include a new algorithm detailing perioperative DAP strategies based on this evidence.
What's a typical DAPT regimen recommended, say, around C?
Usually aspirin plus clopidogrel. Started 48 to 72 hours before CAS, continued for at least 4 to 6 weeks after while the stent endothelializes. Ticlopidine isn't used now. Reasonable doses might be 325 milligram aspirin daily for 14 days, then 75-81 milligram, if aspirin naive, plus clopidogrel.
And what about DDPT for CEA? Historically, surgeons were wary due to bleeding concerns.
That's true. The perceived risk of neck hematoma made surgeons reluctant. But attitudes are shifting. Audits show increasing use of aspirin plus clopidogrel for CEA patients up to 50% in a recent Danish audit.
Is there evidence supporting DPT use even with CEA? Does it reduce stroke risk?
Yes. Large national registries suggest aspirin plus clopidogrel actually reduces perioperative stroke risk, especially early post-op thromboembolic stroke in CEA patients.
But what about the bleeding? Specifically neck hematoma, the big worry.
That's the critical question. Re-exploration for hematoma is serious. However, a vascular study group of New England registry audit found no evidence that aspirin plus clopidogrel was associated with significantly higher rates of re-exploration for neck hematoma. Rates were around 1.4% across groups, including DAP.
That's potentially reassuring data. So what's the overall recommendation for perioperative DDPT in symptomatic patients?
Recommendation 54, new, suggests DAPT may be considered in recently symptomatic patients selected for CEA or CAS before the procedure and continued for a limited time after CAS. Class 2B, Level C. There's a detailed algorithm to guide strategies. Alternatives for allergy intolerance and criteria for high GI bleeding risk are also detailed elsewhere.
What if a patient can't tolerate both, or monotherapy is preferred?
Clopidogrel 75 mg daily is mentioned as an alternative monotherapy if aspirin to pyridamole intolerant. The CAPI trial showed benefit versus aspirin in general vascular disease, though not specifically in the stroke subgroup or peri-CEA setting.
Yeah.
A loading dose, 300 mg, can give rapid effect if needed.
Speaking of bleeding risks, the guidelines explicitly call CEA a high risk of bleeding operation. What factors increase risk, and what are the consequences of a neck hematoma?
Factors include Haspility score 3, recent bleeding, low platelets, previous bleeding issues. The high-risk label is supported by data like that SVS VQI audit showing significantly higher in-hospital stroke, MI death, and stroke death rates in CEA patients re-explored for neck hematoma compared to those without.
How much higher?
Substantially.
Yeah.
Stroke, 3.7% versus 0.8%. MI, 6.2% versus 0.8%. Death, 2.5% versus 0.2%. Stroke death, 5% versus 0.9%. All highly significant differences.
That data really hammers home the importance of meticulous technique and especially post-op blood pressure control to minimize this complication.
Absolutely.
One final point here. Antiplatelet response high on treatment platelet reactivity, HTPR, sometimes called resistance. What is it, and should we test for it?
HTPR means lab tests suggest a patient's platelets aren't being well inhibited by their antiplatelet drug, like aspirin or clopidogrel. A meta-analysis of observational studies found patients with HTPR had almost 3 times the risk of recurrent TI stroke, MI, or vascular death compared to those without HTPR.
So if a test shows HTPR, they seem to be at much higher risk observationally. Does that mean we should routinely test carotid patients for HTPR to guide treatment?
This is a key clinical point. The guidelines state clearly that no studies to date have been adequately powered to determine if HTPR status, measured by these lab tests, actually predicts ischemic or hemorrhagic event risk, specifically in carotid stenosis patients, either perioperatively or long-term.
So the specific evidence in the carotid population is lacking.
Correct. Based on that lack of specific evidence, Recommendation 55, new, states routine ex vivo HTPR testing to tailor antiplatelet regimens is not recommended in individual carotid stenosis patients. It should only be done in research study and use trials. Class 3, Level B.
Class 3 is a strong recommendation against routine use.
Yes. Current major guidelines don't recommend routine testing. Ongoing research with multiple platforms is important, but for now, it's not ready for routine clinical practice in this group.
Okay, we've completed a deep dive into symptomatic carotid disease management. Timing after symptoms and thrombolysis, managing AF and anticoagulation, DAPT evidence and risks, and the current stance on HTPR testing. That's sections 4.2 through 4.8 and 4.16 covered. Let's take a mega recap of symptomatic disease.
Okay. Key updates for symptomatic carotid disease. Strong recommendation for prompt revascularization, ideally within 7, definitely within 14 days. After mild-moderate stroke TIA, Class 1 Level A, due to high early recurrence risk. CEA appears safer than TFCAS for stroke risk within 14 days, but guidelines retain the 6% risk threshold to avoid delays. Intervention contraindicated in unstable patients. Large infarct deficits. New guidance. Minimum 6-day delay for CEA after thrombolysis, Class 2A, Level B. For bleeding risk, open question for those without infarct. New algorithms recommendations for managing concurrent AF or anticoagulated patients peri-intervention. New emphasize evidence supporting perioperative DAPT in recently symptomatic patients may reduce stroke risk even with CEA without significantly increasing hematoma rates, Class 2B, Level C. Routine HTPR testing to guide therapy is not recommended, Class 3 Level B, due to lack of specific evidence in carotid patients.
That was a truly comprehensive summary. Now let's shift gears to the intervention techniques themselves and their outcomes, starting with carotid endarterectomy, CEA.
Right, the standard open operation. Incision in the neck, expose the artery, give heparin, clamp above and below the blockage, open the artery, maybe use a shunt to maintain brain blood flow, remove the plaque meticulously, and then usually close with a patch vein or synthetic to widen the artery slightly and reduce restenosis risk. Takes about an hour or 2 usually.
Now the long-standing debate, general anesthesia, GA, versus locoregional anesthesia, LRA, where the patient's awake. What's the latest evidence cited?
A meta-analysis pulled 5 RCTs and 7 observational studies. Overall, no significant difference in the main composite outcome. 30-day death stroke MI.
Okay.
However, the meta-analysis did suggest higher rates of some specific complications, like cranial nerve injury, MI, and death with GA.
But there's an important nuance there, right? Driven by observational studies.
Exactly, and observational studies can have selection bias. Maybe higher-risk patients get GA preferentially, inflating the rates. The randomized trials didn't show those same differences clearly. Observational data also suggested more cranial nerve injury, longer op times, more transfusions with GA. But the large GLA RCT found similar neck hematoma rates in both groups.
So the evidence is somewhat mixed, making a definitive recommendation difficult.
Yes. And related to this, there's that specific concern about neck hematoma risk with combination antiplatelet therapy combined with LRA, especially deep cervical plexus blocks.
Right?
Most LRA studies were done with aspirin monotherapy. With more DFPT use, is there more bleeding risk if you block deep nerves? A systematic review found higher complications with combined deep plus superficial blocks versus superficial intermediate only. But there's no specific guidance on hematoma risk with deep blocks in LRA patients on DAPT. Needs more data.
Understood. Moving to the technical side of CEA, what about imaging during the operation?
Recommendation 77, new, suggests considering intraoperative completion imaging angiography, duplex ultrasound, or angioscopy after closing the artery but before closing the neck. The idea is to reduce perioperative stroke risk, Class 2A, Level C.
And the basis for considering that?
A meta-analysis showed a relative risk reduction for stroke, RR 0.48, when completion imaging was used, suggesting it helps catch technical issues early. However, the SVS guidelines concluded there wasn't enough evidence to recommend it routinely, so there's some differing interpretation there.
Okay, let's transition to carotid artery stenting, CAS. What does that involve?
It's endovascular, usually accessed via the femoral artery in the groin, though other routes exist. Catheter navigated up to the carotid, wires carefully cross the stenosis. Then, crucially, a brain protection device is used.
To catch debris.
Exactly. Prevent emboli going to the brain during the procedure. Once protection is in place, a mesh tube is positioned across the narrowing and deployed, usually expanded with a balloon, to open the blockage.
You mentioned brain protection devices. Different types.
Yeah.
Is one better?
Common types are distal filters, deployed beyond the stenosis to catch debris, and proximal protection systems, temporarily block flow below the stenosis during stenting. No RCTs directly compare them head-to-head.
But consensus is to use some protection.
Strong consensus, yes. Minimize procedural embolization risk. A meta-analysis did suggest proximal protection might be associated with fewer new post-operative ischemic brain lesions, which we'll discuss.
What about the access site for CAS? Mostly femoral, but alternatives.
Yes. Recommendation 82, new, suggests considering transradial access, wrist, or transcarotid artery revascularization, TCR, as alternatives to transfemoral CS. Especially if transfemoral access is higher risk due to aortic arch disease or complex groin anatomy, Class 2A, Level B.
TCA is relatively newer.
It is. Involves a small neck incision to directly access the common carotid, uses flow reversal for brain protection during stenting. It's promising. But the guidelines note outcome data specifically stratified by timing post-symptom onset, like within 7 versus 8-14 days, is still limited for TCIR compared to TFCAS or CEA.
Let's talk about operator and hospital experience volume. Does practice make safer?
Yes. Compelling evidence links volume to outcomes for both CEA and CAS. For CEA, hospital volume inversely relates to stroke, death, in elective patients, though defining a threshold is hard. For surgeon volume, some studies show an inverse relationship, others less so after adjustment.
Are there suggested minimum annual volumes for CEA surgeons?
Some studies suggest thresholds like 30-year or 18-year associated with lower risk. An interesting finding. Specialist vascular training helped outcomes for low-volume surgeons, but not high-volume ones where experience seemed key regardless of training background. Optimal annual CEA volume remains an unanswered question.
What about volume for CAS? Similar link.
Yes. A strong link for CAS operator volume. The CSTC meta-analysis found higher 30-day death stroke with lower volume operators, 3.2-year, versus higher volume, 5.6-year. They concluded minimum 6 SACE-year needed for competence.
Others suggest higher numbers.
Yes, like 25 lifetime plus 10-15 annually. An Australian NZ audit showed higher risk 11-year versus 12. The CHOICE registry found operator volume, not hospital, predicted adverse outcomes, with risk increasing the longer the time between cases for an operator. SVS made no volume recommendation. German-Austrian advised hospitals 10-year. Optimal annual CAS volume is also listed as unanswered.
So for both procedures, experience matters. Higher volumes generally correlate with better outcomes, but precise minimums are debated.
Correct. Procedures should ideally be done by experienced operators in centers with adequate volume and support.
Let's take a quick micro recap on intervention techniques and volume. We've described CEA and CAS procedures, the GA versus LRA debate for CEA, potential role of completion imaging, access, and brain protection for CAS, and the evidence linking volume to outcomes for both, noting higher volume generally means better results but lack of definitive thresholds.
Okay, moving on from procedures, let's talk post-procedural complications and surveillance. A concept getting attention is new post-operative ischemic brain lesions, NIBLs. What are they?
NIBLs are small, often asymptomatic areas of new stroke seen on post-op brain MRI, especially diffusion-weighted imaging, DWI.
Right. Data from the ICSS trial comparing CEA and CAS in symptomatic patients is key here. In their MRI substudy, 50% of CAS patients had NIBLs versus only 17% of CEA patients.
Oh, 5 times more likely after stenting in that trial.
Yes, odds ratio 5.21 favoring CEA. Even at 1 month, persisting flare changes were higher after CAS, 33% versus CEA, 8%. This finding is consistently confirmed in meta-analyses, maybe 40% NIBLs post-CAS versus 12% post-CEA.
Are there predictors for who gets NIBLs?
Yes. For CEA, prior TIA stroke impaired CVR inflammation. For CAS, increasing age, vulnerable plaque features, complex anatomy. And as mentioned, maybe proximal protection reduces NIBLs compared to filters during CAS.
What's the clinical significance? If they're often asymptomatic, do they matter long-term?
That's the big question. In the carotid RCTs, a clear link between NIBLs and later cognitive impairment wasn't consistently found. Maybe trials were underpowered. But the neurovision study in non-cardiac surgery patients did find a link.
What did neurovision show?
7% developed NIBLs post-op. Of those, 42% had cognitive impairment at 1 year versus 29% without NIBLs. Hazard ratio near 2, suggesting NIBLs predicted cognitive decline.
What about future strokes or TIAs? Any link there?
Yes, ICSS found patients with NIBLs had significantly higher 5-year recurrent strokia rates, 22.8%, HR 2.85. Neurovision also reported increased strokia at 1 year with NIBLs, HR 4.13.
So NIBLs might be a marker, a warning sign for future cerebrovascular events.
Exactly.
Yeah.
The ICSS authors speculated maybe patients with NIBLs need more aggressive prolonged DBT, but that's untested. Looking forward, NIBLs might become a useful surrogate endpoint for trials, could reduce sample sizes needed.
But currently no specific guideline recommendations on preventing or managing NIBLs.
Correct. It remains an active research area.
Let's shift to another post-procedural issue. Restenosis, re-narrowing after intervention, and surveillance with duplex ultrasound. Is routine surveillance recommended for everyone?
No. The guidelines state clearly, no evidence supports routine surveillance in all CAS patients.
But maybe for subgroups at higher risk of restenosis.
Yes, it's considered reasonable to assume those with risk factors might benefit. Risk factors include diabetes, chronic kidney disease, being female, continued smoking.
So targeted surveillance based on risk factors.
Exactly. Recommendation 106, new, suggests considering DUS surveillance for patients with restenosis risk factors based on shared decision-making and local policy. Class 2B, Level C.
Is there any specific scenario where re-intervention for asymptomatic restenosis is specifically recommended?
Yes, one very specific scenario. Recommendation 107, unchanged, recommends serial surveillance and considering reintervention for asymptomatic restenosis 70% only in CEA patients who had significant ED changes or very low MCA velocities, 15 cm/sec, on TCD during clamping under GA. Class 1, Level C consensus.
It's very specific, tied to intra-op monitoring. What about the general stroke risk from asymptomatic restenosis after either procedure?
A meta-analysis looked at this. For CAS patients who developed 70% asymptomatic restenosis, the 5-year ipsilateral stroke rate was low, 0.8%, and not significantly different from those without restenosis.
So asymptomatic in-stent restenosis didn't seem high risk for late stroke in that analysis.
Based on that pooled trial data, apparently not. However, it was different after CEA. 70% asymptomatic restenosis after CEA was associated with a significantly higher 3-year ipsilateral stroke risk, 5.2%, versus 1.2% without restenosis. Odds ratio nearly 5.
So restenosis after CEA seems riskier for late stroke than after CAS, based on this data.
It appears so from this meta-analysis, but the guidelines highlight the clinical dilemma. Even with that higher risk, operating on 100 asymptomatic 70% restenosis post-CEA might prevent only about 5 strokes over 3 years, at the cost of 2-3 perioperative strokes from the redo procedure. Plus, most late strokes post-CEA happen in patients without 70% restenosis anyway. It's complex.
If revascularization is needed for restenosis, what are the options?
Redo CEA, surgical bypass, or CAS. These haven't been directly compared in RCTs for restenosis.
What do observational data suggest comparing redo surgery versus stenting for restenosis?
A meta-analysis found similar 30-day stroke rates, around 2 to 2.6%. But redo CEA has significantly higher permanent cranial nerve injury, 3.3%. 0%. SVS VQI data on treating in-stent restenosis also showed similar 30-day stroke comparing redo CEA versus redo CAS, around 1.5%. Maybe a trend favoring redo CAS for death stroke composite.
So, based on observational data, CAS might be preferred for treating restenosis due to lower nerve injury risk, and maybe for in-stent restenosis too.
The guidelines don't state a strong preference. Recommendation 108, unchanged, says the choice, redo CEA or CAS, should be based on MDT review, local expertise preference, and patient choice. Class 1, Level C consensus.
Let's briefly touch on other post-op complications after CEA. Wound hematoma.
Yes, most occur in the first 6 hours, often linked to uncontrolled hypertension post-op. Meta-analysis showed 2.2% need re-exploration. GAA trial showed similar rates GA versus LRA. And as we discussed, SVS-VQI data shows re-exploration for hematoma is linked to significantly higher in-hospital stroke MI death risks.
What about complications after CEA beyond restenosis?
Post-procedural hypertension is also a concern after CAS, similar to CEA. Required treatment in about 10% in one SVS VQI database, and was associated with higher stroke death risk.
And there's a general recommendation about managing post-procedural hypertension.
Yes, recommendation 97 unchanged. Centers performing carotid interventions should have written criteria for treating post-procedural hypertension. Class 1, Level C.
Finally, hyperperfusion syndrome, HS. What is that?
A potentially serious complication after revascularization, though no consensus definition. Affects maybe 1% post-CEA, 3% post-CAS. Symptoms include severe headache, confusion, seizures, hypertension, decreased consciousness, nausea, vomiting, focal deficit.
When does it typically occur?
Average onset 12 hours post-op. It can be immediate or up to 4 weeks later.
And on MRI, what does it look like?
Typically vasogenic edema, swelling from leaky vessels, often not confined to the carotid territory. Perfusion imaging shows excessive flow. T2F flare MRI shows high signal without restricted diffusion, unlike stroke. May see high T1 signal if there's hyperacute hemorrhage.
Sounds like tight blood pressure control post-op is absolutely critical to prevent this potentially devastating complication.
It is. Aggressive management of post-op hypertension is considered the cornerstone of prevention.
Okay, we've covered a lot on intervention techniques, outcomes, and post-procedural issues like NIBLs, restenosis, hematoma, hypertension, and hyperperfusion. Let's take a moment for a mega recap of this section.
Okay. Recap on interventions, outcomes, complications. Guidelines describe CEA and CAS. CEA, GA versus LRA debate continues. Mixed evidence, potential bias. Completion imaging may be considered, Class 2A. CAS, brain protection essential. Alternative access, transradial, TCR discussed. TCR, timing data limited. Volume, strong evidence links operator volume and hospital volume to some extent to outcomes for both higher volume, better results, but optimal thresholds unclear and answered. Post-procedure. NIBL is more common post-AS versus CEA, may predict future events, but no specific management recommendations yet. Routine restenosis surveillance not for all. Consider for high-risk patients, Class 2B. Re-intervention for asymptomatic 70% restenosis only recommended post-CEA with specific intra-op findings, Class 1. 70% restenosis post-CEA seems riskier for late stroke than post-CEA based on meta-analysis, but re-intervention decision complex. Other complications. Wound hematoma, serious risk factor. Post-procedural hypertension needs protocol. Hyperperfusion syndrome, rare but serious linked to hypertension.
That was a thorough review. Now, let's turn to managing patients with carotid disease alongside other significant conditions, concurrent cardiac disease needing CAB, or disease in the supraaortic arteries proximal to the carotids. Starting with the tricky scenario. Carotid stenosis plus needs CABG.
Yes, complex clinical scenario needing careful MDT assessment. Guidelines discuss managing carotid stenosis, especially asymptomatic, in patients needing CABG. Different timing strategies exist. Stage CEA, then CAG, stage CABG, then CEA, or synchronous CEA plus CEG in one operation.
What does the evidence show comparing these strategies?
Meta-analyses and trials show varying outcomes. It's complex. Some studies suggest potential benefit for staged or synchronous CEA versus deferred CEA after CABG, maybe reducing stroke in certain subgroups like unilateral 70-99% ACS needing CABG, Illuminati trial.
But conflicting findings too.
Yes. The CABCS trial, though underpowered, suggested higher 30-day stroke death with synchronous CEA plus CABG versus CABG alone in unilateral 80-99% ACS.
What about comparing combined surgery, synchronous CEA plus CABG versus staged CAS, then CEB?
A meta-analysis found similar periop stroke MI rates, but higher overall mortality with synchronous CEA plus CEG compared to staged CAS, then CABG.
So the optimal strategy for carotid plus CABG is still complex and debated, needing individual assessment.
Absolutely. The guidelines reflect this complexity. No single algorithm. Requires careful individual risk assessment, carotid risk, cardiac risk, procedural risks, and MDT discussion.
Let's look now at supraaortic artery disease affecting proximal common carotid or innominate artery. Treatment options.
Generally, open surgery, bypasses, transposition, endarterectomy, or endovascular angioplast-stenting. Historically, open surgery was the mainstay.
How do outcomes compare between open and endo for these proximal lesions?
A meta-analysis of observational studies compared them. Open surgery, mostly innominate. Higher 30-day death stroke, 7%, but good late patency low restenosis, 2.6% at 12Y. Endovascular, mostly innominate. Lower 30-day death stroke, 1.5%, but higher late restenosis, 9% at 4Y.
So endo safer short-term, but maybe less durable long-term for these proximal lesions.
That's what this meta-analysis suggests. Also, tackling tandem lesions, proximal plus ICA, endovascularly seems riskier than isolated ICA stenting based on a VSG&E audit.
Given the risks, is intervention recommended for asymptomatic proximal common carotid innominate stenosis?
No. Recommendation 123, unchanged, clearly states open or endo interventions are not recommended for asymptomatic proximal disease. Class 3, level C, intervention not supported, potentially harmful.
What about symptomatic patients? Symptoms like dizziness, arm weakness, stroke related to flow.
For symptomatic proximal CCA or IA stenosis, recommendation 124, unchanged, says open retrograde angioplasty and stenting should be considered. Class 2A, level C.
And the open surgical options, cervical versus transthoracic.
Cervical neck approach is less invasive, good for isolated subclavian CCA lesions if healthy inflow vessel exists in neck. Transthoracic opening chest is more invasive, needed for complex arch branch disease involving aorta origin, but often offers better long-term patency for complex cases. Performed with low morbidity mortality in experienced centers.
Okay, let's take a micro recap on managing concurrent disease.
Quick recap. Concurrent disease. Managing carotid stenosis plus CABG is complex, requires individual assessment, varying strategy outcomes for staged versus synchronous approaches. Supraaortic disease, proximal CCAIA. Intervention not recommended for asymptomatic lesions, class 3. For symptomatic stenosis, open retrograde angioplast stenting may be considered, class 2A. Open surgery ranges from less invasive cervical to more complex transthoracic bypasses depending on disease extent.
Now let's turn our attention to the management of vertebral artery VA disease, affecting vessels supplying the back of the brain. First, the cause of vertebrobasilar VB strokes. How common?
About 20% of ischemic strokes are VB territory. Main causes similar to anterior circulation, cardioembolism, large artery atherosclerosis, small vessel disease. Atherosclerosis of the vascular artery accounts for 20-25% of VB strokes.
Where do these narrowings usually occur?
Most commonly at the VA origin from the subclavian artery, but can affect VAs further along, including intracranial segments. Intracranial stenosis are more common in certain ethnicities.
Was it thought low flow, hemodynamics was the main cause of symptoms?
Often suspected, yes.
Yeah.
But evidence suggests thromboembolism, bits breaking off plaque, is the main cause of symptoms from VA stenosis, rather than just low flow alone, except maybe in severe bilateral intracranial disease.
What are typical symptoms of VA disease VB stroke day?
Common ones include dizziness, 47%, unilateral limb weakness, 41%, dysarthria, 31%, headache, 28%, nausea vomiting, 27%. Also visual issues, vertigo, swallowing problems, instability. Recently symptomatic means within 6 months.
How should we image the VA system? Shift away from invasive angiography?
Yes, significant shift to non-invasive CTA or SEMRA. They show the whole system, extracranial and intracranial. DSA is rarely first line now.
How accurate are these non-invasive methods for VA stenosis?
Systematic review showed CTA very accurate, 100% sensitivity, 95% specificity. CMRA, also good, 94% sense, 95% spec. Duplex ultrasound, lower sensitivity, 70%, but high specificity, 98%.
Limitations of duplex for VAs.
Good for proximal VA origin and V2 segment in neck bones, but often can't see distal VA entering skull or intracranial parts well. Disease there inferred from flow waveforms. Still useful for size, flow direction, Steele syndrome, differentiating stenosis occlusion hypoplasia. Primary method for subclavian Steele diagnosis.
And for seeing actual VB infarcts.
MRI is more sensitive than CT, especially for small brainstem lesions. DWI is best for acute ischemia, up to 2 weeks.
What about medical therapy for VA disease, same as carotid?
Yes, the guidelines state all patients with stroke TIA from VA narrowings benefit from the same comprehensive lifestyle advice: risk factor control, BP, lipids, diabetes, and medications, antiplatelets, statins. As for carotid disease, optimal medical therapy is foundational.
Regarding revascularization like stenting, is that common for symptomatic VA stenosis?
Open surgery is very rare now. Most symptomatic VA stenoses are treated with medical therapy alone. When intervention is done, it's almost always endovascular stenting.
What do the randomized trials show comparing stenting versus medical therapy for symptomatic VA stenosis?
Key evidence from a meta-analysis of individual patient data from vast SAMPRIS trials. Over 350 symptomatic patients, 99% of basilar stenosis.
Key findings: periop risks, long-term outcomes.
Significantly higher perioperative stroke death after stenting versus BMT alone. Crucially, risk varied hugely by location. Intracranial stenting had very high 16% periop stroke death risk, much higher than the 1% risk with extracranial stenting.
Wow, intracranial stenting, very risky short-term in those trials. What about long-term stroke prevention?
Critical finding. At 5 years follow-up, there were no statistically significant differences in stroke rates between the stenting group and the BMT alone group overall.
That's huge. Higher short-term risk, especially intracranial, but no long-term stroke prevention benefit versus just BMT.
Exactly. There was one subgroup analysis looking at early presenters, 14 days, suggesting a non-significant trend towards benefit with stenting, HR 0.65, but interpret cautiously.
Based on this evidence, higher periop risk, no overall long-term benefit versus medical therapy. What's the guideline recommendation for VA stenting?
Recommendation 126, new states VA stenting may be considered in symptomatic patients with significant 50% extracranial VA stenosis who have recurrent symptoms despite optimal medical therapy. Class 2B, level B.
Class 2B may be considered not strong. How do U.S. guidelines compare?
Differently, SVS advises open surgery for low-risk symptomatic proximal VA stenosis, no mention of distal stenting. AHA says no proven role for VA stenting in symptomatic patients. So ESVS Class 2B is slightly more permissive than AHA, but still very cautious.
Regarding endovascular techniques for VA stenting,
Medical therapy similar to CAS, DPT, statins, heparin, access usually femoral, 93%. Small Weir's balloon stents. Coronary balloon expandable stents often preferred for origin tortuous vessels. Self-expanding for larger VAs. Optimal ostial coverage can be tricky. Dual balloon technique option.
drug-eluting stents, DES versus bare metal stents, BMS for VAs.
Meta-analyses of non-randomized studies. No difference in technical success procedural complications. But BMS patients had significantly more recurrent symptoms and reinterventions than DES patients.
So DES seem more durable for VAs, preventing restenosis symptoms better.
Yes, available data suggests that, similar to coronaries.
Typical perioperative complications with VA stenting.
Systematic review of non-randomized studies reported low rates. Stroke, 0.3%. Access issues, 0.7%. Dissection, 0.5%. No specific studies on managing procedural stroke after VA stenting advised treating SARA post-CS.
And in-stent restenosis after VA stenting.
Systematic reviews show ISR rates and, again, better outcomes, lower restenosis with DES versus BMS.
Okay, that covers VA disease management thoroughly. Let's take a final mega recap of this section.
Mega recap: VA disease. VB strokes, 20% ischemic strokes. Thromboembolism from proximal stenosis main cause, not just low flow. Symptoms: dizziness, weakness, dysarthria common. Imaging: non-invasive CT preferred over DSA. Duplex useful proximally for flow. OMT, risk factors, meds, is foundational treatment. RCTs: VA stenting had higher periop risk, is very intracranial, 16% versus BMT, with NO overall long-term stroke prevention benefit. Guideline: VA stenting may be considered, Class 2B level B, only for symptomatic 50% extracranial stenosis with recurrent symptoms despite OMT. Differs from some U.S. guidelines. Endo techniques primary option, DES, appear more durable, less restenosis symptoms versus BMS.
That was an incredibly detailed deep dive into clinical management. Beyond recommendations, the guidelines crucially highlight unanswered questions, areas needing more research. What are some key ones?
Several critical ones. Is stroke risk on modern BMT in asymptomatic patients truly lower than when ACAS-XT1 recruited? Directly impacts relevance of older trials.
Right, and linked to high-risk asymptomatic patients.
Is 80-99% ACS alone associated with higher late stroke versus 60-79%, even with similar plaque features? Clarifies if stenosis degree itself warrants intervention sometimes.
Potential role for blood tests.
Can plasma biomarkers help improve risk stratification in ACS-SCS?
And the cognitive function link.
Does severe ACS definitively cause cognitive impairment? Can interventions reverse or prevent decline? Still a major question.
Specific drug therapies.
Effectiveness of low-dose rivaroxaban plus aspirin versus aspirin alone in ACS patients, referencing COMPASS trial context.
Timing after thrombolysis.
For symptomatic patients post-TT with no acute infarct on imaging, do they still need the 6-day wait before intervention?
Newer endo techniques like TCA.
Can TCA be done safely within 7-14 days post-symptom onset with risks similar to CEA? Timing data still limited.
GA versus LRA for CEA.
Is CEA under LRA safer than CA in symptomatic high risk for CEA patients? Cardiac pulmonary disease? And fundamentally, should LRA be preferred over GA for most CEA patients?
Less common scenarios.
Can carotid revascularization improve vision in established neovascularization-related glaucoma?
Procedural monitoring.
Role for routine pre-post-op troponin measurement in CATs patients.
Volume outcome relationship.
What optimal annual hospital or surgeon CEA volume is needed to maintain competent safety? Still unanswered.
And relating back to VA disease and antiplatelets.
Role for VA stenting within 2 weeks of TS stroke in extracranial VA stenosis, given that subgroup trend. And is there a role for routine HTPR testing to guide antiplatelet adjustment in carotid patients? Current evidence says new outside research.
That's a really comprehensive list of where knowledge gaps remain, driving future research.
Absolutely. Shows even with extensive guidelines, fundamental questions persist.
To wrap up, the guidelines include a new information for the patient section. While for patients, it often contains core concepts useful for us clinicians communicating complex info. What are some key pearls from that section?
It explains atherosclerosis basics, simply plaque, stenosis, occlusion, bifurcation. Clarifies asymptomatic, no symptoms, incidental finding, versus symptomatic, cause TI stroke.
And they use that simple S mnemonic for TI stroke symptoms?
Yes, reinforces crucial symptoms. Sudden problems with sight, speech, swallowing, strength, sensation, stability. Critical message. Seek immediate medical help or call ambulance for these. Very actionable for patients.
Good reminder for our communication.
It also reiterates that most people with severe ACS will not have a stroke over 10 years if they follow lifestyle meds advice. Interventions are for the smaller high-risk group based on specific features, not just narrowing percentage.
Helps set realistic expectations. Medical therapy is baseline for everyone. Intervention is targeted.
Exactly. Strongly reinforces permanent lifestyle changes, and medication adherence are vital for controlling risk, preventing recurrence. Minimizing restenosis applies to all patients, intervention or not.
And for VA disease, key message for patients.
Also benefits significantly from OMT. Stenting may be considered for recurrent symptoms despite OMT, reflecting the Class 2B recommendation.
The patient info also encourages patients to know their numbers.
Yes, know their BP, lipid goals, blood sugar if diabetic, empowers them to work with the team, restates the specific targets, also reassures them doctors consider many factors, age, imaging, symptoms, preference, when planning intervention, highlighting shared decision-making.
And includes simplified procedure explanations.
Yes, descriptions of CVA, incision, clamp, shunt option, plaque removal, patch, and CA, catheter wires protection stent. These, maybe with diagrams, are great tools for clinician explanations. Finally, reinforces ongoing lifestyle meds are permanently important post-procedure to prevent recurrence or restenosis, listing risk factors like diabetes, CKD, female sex, smoking, poor B lipids.
So even the patient section offers valuable reminders and communication strategies for us.
So we've completed a truly comprehensive deep dive into the 2023 European Society for Vascular Surgery guidelines on managing atherosclerotic carotid and vertebral artery disease.
Yeah, it's fascinating how much has evolved since 2017. Significant updates to BMT targets, Whole new sections on things like free-floating thrombus, carotid webs, managing patients with AF, intervening in anticoagulated patients, or post-thrombolysis.
We've parsed through the extensive evidence comparing CEA and CAS, highlighted that critical importance of timing interventions after symptoms or thrombolysis, and reviewed the nuanced data on managing asymptomatic disease, identifying higher-risk patients by more than just percentage stenosis.
Right, looking at plaque features, hemodynamics, and we explored the evidence, or lack thereof, for interventions in VA disease, clarifying where stenching might be considered for extracranial lesions with recurrent symptoms despite medical therapy, which, as you noted, differs from some other guidelines.
And this entire body of work, while synthesizing vast data into recommendations from Class 1 down to Class 3 with evidence levels A, B, C, also honestly flags where our understanding is still incomplete. Those unanswered questions really drive the research agenda.
Applying these guidelines means not just knowing the recommendations, but appreciating the strength of evidence behind them, recognizing ongoing debates like intervention in asymptomatic disease today, and always remembering the fundamental importance of optimal medical therapy for everyone.
Exactly. It reinforces that managing this disease is complex. It requires careful patient selection, nuanced understanding of risks and benefits for different interventions at different times, and a strong commitment to multidisciplinary care involving stroke neurologists, vascular surgeons, interventional radiologists, anesthesiologists.
For you, the specialist clinician listening, the real value here is integrating this comprehensive evidence into your daily practice, balancing these guidelines with individual patient factors, and engaging in robust shared decision-making. So consider this. How might the specific detailed blood pressure and lipid targets outlined here potentially change how you counsel and manage some of your asymptomatic carotid stenosis patients compared to before?
And maybe in your next symptomatic patient needing revascularization, how will the data we discussed on timing influence your strategy, especially if they've just had thrombolysis or also have atrial fibrillation?
Keep exploring, keep questioning the evidence, and keep making those evidence-based decisions for your patients.